Well, thank you everyone for being here and for partners coming. This is actually, I've given this talk before, or a variation of it, but not with partners involved. And this is so important, partners, that you are here, because this is really a conversation, what I'm going to be sharing today. So I'm just glad you're all here. So let's get started. I'm going to be talking about 3 different women in this presentation, so I'm going to introduce the women first. The first woman is Sarah. And she says, I have no sexual interest. If I didn't have sex for the rest of my life, I'd be fine. So 38-year-old heterosexual married woman, breast cancer status post total abdominal hysterectomy and bilateral salpingo-oophorectomy. The second woman is Nancy. Nancy says, we haven't had sex in 5 months. It hurts too much, I'm desperate. 49-year-old heterosexual married woman, breast cancer status post total abdominal hysterectomy and bilateral salpingo-oophorectomy. And then finally, we'll talk about Kelly. And Kelly says, I can't even look at my breasts, let alone let my wife look. I haven't let her touch me since surgery. She's a 29-year-old lesbian married woman, stage 2 breast cancer, status post bilateral mastectomy. So we're gonna talk about these 3 women today, what they've been through, what the treatment options are, how you too, if any of you are experiencing any of these, or you hear any of these women and go, oh my gosh, that's me, we're gonna talk about what do you do with that, and how does your partner help you with this? So just a little mini quiz, you cannot fail this quiz. Between what percent and what percent of breast cancer survivors would you say report sexual health concerns? And you can just yell it out. What percent to 1%? 100. 100.
That actually report? Yeah, like 25.
Okay, are you ready? And it depends on the research study you look at, but it's between 70 to 90%, so that 100 number is pretty darn close. And you all know this. This is why you're here. This is a massive concern for breast cancer survivors. And here's the deal. These sexual health concerns, sexual dysfunction, they do not get better over time unless they're treated. So if any provider ever tells you like, oh, you're having sexual pain, well, just wait a while, it'll get better. No, these do not get better over time unless there is treatment. And there absolutely is treatment, so we'll be talking about that today. So what do you do if you're experiencing any of these concerns? Well, first of all, I just wanna and this is the title of the talk too, but I cannot emphasize this enough. Breast cancer does not take away your sexuality. So if you have this mindset that, well, breast cancer's taken so much from me, now it's just taking away my sexuality, it does not. Things have changed, things are going to change, but you absolutely will maintain your sexuality. It may just look a little different. So it does not take away your sexuality. There absolutely there's treatment for the sexual health side effects after breast cancer. We will talk about these. So here's what we're going to talk about today. We're going to talk about the most common sexual side effects. Specifically, we'll talk about these 4. We'll talk about low sexual desire, sexual pain, poor body image, and what's called an avoidant sexual dynamic, which I'll explain in a little bit. We're going to talk about how to treat these, and then how do you navigate your sexual relationship in the context of these. Let's start with low sexual desire. So this brings us to Sarah. So again, Sarah says, I have no sexual interest. If I didn't have sex for the rest of my life, I'd be fine. So to talk about this, I need to share the 2 different types of sexual desire, because there are actually 2 different types of sexual desire, but we certainly do not learn these in sex education. All we see in the movies and media are this first type. So this first type is called spontaneous desire. And that's that type of desire where you have that internal drive, that internal craving, and just you think, yeah, I really want to have sex right now. You just spontaneously think, I want to have sex right now. Okay, so that's spontaneous desire. Movies, media are portraying this, spontaneous desire. But there's a second type of desire that is equally important, that we do not hear about in movies and media, and that is called responsive desire. And here's what responsive desire looks like. You are sexually neutral. Sex is not on your mind. You are not thinking about it. But the right ingredients are in place. Like, let's say you have good energy, there's privacy, you're feeling close to your partner, and then your partner initiates sex, and you're like, well, yeah, I wasn't thinking about it, but yeah, I could be open to it. And then once the sexual activity gets started, once your body actually starts to feel some level of arousal, then you're like, yeah, okay, I'm kind of into this. And then after you have the sexual experience, you're like, gosh, I'm glad we did that. Why don't we do that more often? That's called responsive desire. Equally important as spontaneous. Now I want to show you responsive desire pictorially. I know this probably looks really complicated, but I'm going to walk you through it. This is called the circular model of desire. I would bet every single one of you, every single one of the women in this room endorse this model of sexual desire. There's 2 different models, but I'm just going to share this one right now. The circular model of sexual desire. So let me walk you through. This is likely how you respond sexually, how your desire gets started. Now it could get started because you just happen to have spontaneous sexual drive. So maybe in just in a random moment you think, oh, I really want to have sex right now. And then you seek out a sexual stimuli. You seek out a book or a movie. Maybe you just are feeling aroused in that moment, but you just happen to have spontaneous sex drive, and that's what gets this kick started. Okay, maybe that's going to be the smaller, I think, percentage of time that your desire gets kick started. Now here's the other way. You have that receptivity. So you have that receptivity, the ingredients are in place that allow you to be receptive, and everyone has different ingredients, and so it might be, again, that you've got good energy, you're feeling close to your partner, maybe you're feeling good about your body, and then there's some sort of sexual stimuli, maybe that's your partner initiating. So your partner says, hey, you want to have sex, or maybe starts to give you a massage. As long as biologically and psychologically everything's in check. Biologically, you are not feeling ill in that moment, you don't have a massive headache. Psychologically, you don't feel super stressed out. Anxious, depressed, as long as these are in check, the first thing that happens is your body feels some level of arousal. So vaginal lubrication, blood flow to genitals, some level of arousal. And then next comes desire. Now this is such an important point. If responsive desire is your main desire, arousal comes first. Your body has to get kick-started. So if your partner just says like, hey, you want to have sex? That's not going to do it. Your body has to get kick-started. Maybe it is a kiss, maybe it is a massage, but your body has to get kick-started. And then on the coattails of that, your mind says, oh yeah, I'm kind of desiring this. And then that leads to some sort of emotional and physical satisfaction, which some people say is orgasm, but orgasm doesn't have to be how you define satisfaction. It could be just the skin-to-skin contact, the closeness. That leads you to feel emotionally intimate with your partner, which leads you to either seek out or be receptive to sexual activity or sexual stimuli in the future. So I'll come back to this later on in the presentation, but I just wanted you to see kind of pictorially how this cycle works. And we'll see the other cycle, which may be your partner cycle, later on. Okay, so anything that changes your hormones is going to change your sexual desire. So when I say anything that changes your hormones, aromatase inhibitors, chemo, oophorectomy, these are going to change your hormones, and that in turn is going to impact your spontaneous desire. And so let me explain why. If you think of spontaneous desire having a gas tank, most of the gas in that gas tank that drives that spontaneous desire is hormones. And in parentheses, I put indirectly. So this is an important point. It's not that if someone were to give you a ton of estrogen and testosterone that all of a sudden you're going to be like, oh, I've got so much spontaneous desire. It's not this direct correlation that hormones equals lots of desire. What we see from the research is that having those hormones reduces all those negative side effects like vaginal dryness, brain fog, fatigue, poor sleep. So all these things that lack of hormones, all these things that make you feel bad because you have a lack of hormones, now putting those hormones in the gas tank take away those negative side effects. And then as a result, you start to feel better. And then you're like, oh, I feel better, now I am open to being sexual. So when I say hormones in the gas tank, it's an indirect relationship. It's not that they magically give you desire, but it's that they take away all those negative side effects so that you feel better enough or good enough to be responsive sexually. Okay, so spontaneous desire, driven in part indirectly by hormones. It's also driven in part by the honeymoon phase. So the honeymoon phase, in the research it's called the limerence phase, but it is the first 12 to 36 months of a relationship, and it is when everything your partner does you think is adorable. Like, they burp and you're like, oh. And that can't last. That simply cannot last any more than 12 to 36 months. But that honeymoon phase drives a lot of that desire, a lot of that novelty. Okay, so if you are, again, aromatase inhibitors, chemo, treatment-induced menopause, like oophorectomy, you don't have those hormones in your gas tank to help drive that spontaneous desire. And if you've been with your partner more than 12 to 36 months, you don't have that honeymoon gas anymore, which leaves you with responsive desire being your main desire, which is still a great desire to have. Just because this isn't the desire that we see in the movies and media doesn't mean it's inferior. This is still a great desire to have, and we're going to talk about how you can tap into it. So to tap into responsive desire, it's really important to know about this thing called the dual control model, which probably does not sound fun at all, but it's actually really cool. So the dual control model is based on this idea that for all of our sexual function, so everybody in this room, for all of our sexual function, it is based on a brake pedal and a gas pedal. And in order for your sexual function to function, in order for you to have desire, you need to have more on your gas than on your brake. So things that hit the brake. If you're not feeling good about your body image, if you're tired, chemotherapy, depression, anxiety, stress, all these things hit the brake. Things that hit the gas. Maybe your partner smells good. They look good to you. There's novelty in that relationship. You feel an emotional connection. Those are all examples of things that hit the gas. Now again, in order for your sexual function to function, in order for you to have desire, you need more on your gas than on your brake. When I see new clients, we do an assessment session, usually if they're coming in with low desire, and I'll say, well, what have you tried? They typically say, well, we've tried a bunch of gas pedal things. They say, oh, we tried lingerie, and we brought in toys. And that's great, but at the beginning, that is not helpful. And here's why. If you think about this brake pedal, this gas pedal, like it's belonging to a car, and you have your foot all the way on the brake, and your foot is to the ground on the brake, and then you decide you're going to put your foot on the gas, what is going to happen to your car? Yeah, like stall, maybe there's a little rev, it's not going to move. So think about that analogy. If there's so much on the brake, it doesn't matter how many toys, date nights, lingerie, the gas is irrelevant. The first line in treatment is figuring out what is on the brake pedal and then removing as much as possible off the brake pedal. Then you can start thinking about gas after that. So the first line is what is hitting that brake pedal and what can be removed. Now I'm going to introduce you to another model because this is going to be a really nice way to organize the most common things that hit the brake pedal. This is called the biopsychosocial model, and it's just a way for us to organize this. There are physiological factors that hit the brakes, there are emotional, psychological factors that hit the brakes, there are relationship factors that hit the brakes, and then there are just like society factors that hit the brakes. I'm going to share with you the most common factors that hit the brakes. So we're going to start with physiological, the most common physiological factors that hit the brakes. And I want you all to really think about, if you have low desire, really think about, well, what's hitting my brake? So as I'm going through this list, whether you're jotting it down or you just have it in your mind, think about for you, what on this list is hitting your brake? Because at the end, it'd be really helpful to have a whole list of all the items hitting your brakes, because that's the start of treatment. That's where you take a step back and go, oh, of all these things, can anything be modified or removed? So this is really good information for you. What is hitting your brakes? So most common physiologically, and again, think about, is this hitting my brake? First of all, of course, chemo. Any medications, especially aromatase inhibitors, they impact hormones. GSM, genitourinary syndrome of menopause, that is when those vaginal tissues dry out, become thin. This is not the best description, but can rip and tear with vaginal penetration. So GSM really hits the brakes because it's pain. It's pain when you have any penetrative sexual activity. Again, like I mentioned before, anything that's impacting your hormones. Fatigue. I'll ask my clients, at the end of the day, if I would hand you a platter of sleep versus a platter of sex, what platter are you going to take? And if they say like, oh, I'm taking that sleep platter, then yeah, fatigue's probably hitting the brakes for you. Most common psychological emotional factors, anxiety. Like if you have your 3 or 6 month checkup with your oncologist coming up and it's just in a couple weeks, I'm sure you are really anxious and kind of scanning the environment for threats and worried about what the results are going to be. And that does not set up an environment to be able to relax and bring blood flow to your genitals and be able to be in a space where you feel safe and vulnerable enough to be sexual. So that hits the brakes on desire. Depression. Hallmark feature of depression is the things that you did find pleasurable, you don't find pleasurable anymore. Low motivation, so that really hits the brakes. Poor body image. If you're not feeling sexy, it's difficult to want to be sexual. Of course, history of sexual abuse or trauma, distraction. So what I'll ask my clients is, when you're actually having sex, what are you thinking about? And oftentimes the answer I get is, oh, I'm thinking about my to-do list, and I can hear the kids in the other room. Like, that is absolutely going to hit the brakes if your mind is distracted while you're being sexual. And then substance abuse. Substances, a little bit can be helpful, but if you go beyond that, it really is a dampener to sexual desire. Okay, most common relationship factors that hit the brake pedal: conflict. If you and your partner have been arguing, and you're not really happy with your partner, it's difficult to want to be sexual with them. No emotional intimacy. If you go back and remember that circular model, the top of that circular model was emotional intimacy. That's a core component to tap into responsive desire. So if you don't feel emotionally connected with your partner, it's going to be difficult to want to be sexual with them. Partner dysfunction. So we know that if your partner has a sexual dysfunction, so let's say your partner you're heterosexual, you have a male partner, if your partner has erectile dysfunction, you are more likely to have a sexual function concern. And inadequate stimulation. If when you think about the sexual experience, you think, ugh, the right buttons aren't going to be pushed, this isn't going to feel that great to me, then that's not a big motivator to want to be sexual if you're not getting the adequate stimulation you need and want. And lack of privacy. I mentioned before that I ask this question to all my clients: when you're actually having sex, what are you thinking about? What's going through your mind? And so many times I hear, I'm worried the kids are going to come in the room. And so my answer is always, well, can you lock the door of your bedroom? And repeatedly, I've had clients tell me, oh, we actually don't have a door in our bedroom. What? Go to Home Depot and get a door. And then societal influences, limited sex education. Most of us did not receive good sex education. Conflict with religious, personal, or family values. And then societal taboos. These all can really hit the brakes. So again, I want you thinking about, for you, if you have low desire, what is hitting your brakes? Now what I'll do, in my office I have a big whiteboard. You don't need a big whiteboard. Take out a piece of paper. And on that paper, you're essentially going to draw the biopsychosocial model in 4 columns: biological, psychological, relationship, life stuff, that's kind of a catch-all for all the societal stuff, and really go through and list out all the things hitting your brakes. So maybe a typical whiteboard in my office might be, I'm having hot flashes and night sweats, and I'm not feeling good about my body image, and my partner and I have been arguing, and I'm in that sandwich generation, so I'm stressed out because I'm caring for my parents and caring for kids. Honestly, a whiteboard in my office has a lot more than this on it, but let's just say this is what's on there. So you'll take a look at your whiteboard or your paper, and I want you to go, okay, out of all these things, what are the top 3 that are hitting my brake pedal? So really circle, what are those top 3 that have the greatest weight on the brakes? And then look at those 3. Can they be modified in any way? Can they be removed in any way? Can your partner help you manage those differently in any way? But the whole purpose is, can you remove as much weight off that brake pedal? And then afterward, you can start thinking gas. Ultimately though, what I want you to take from this is, for most of you, if not all of you, your main desire right now, and perhaps for the rest of your life, is going to be responsive desire. So it is all about figuring out what's your brake gas pedal, how do you remove as much off the brakes, and then add stuff to the gas after that. This is a phenomenal book, Come As You Are, and then it has an accompanying workbook, Come As You Are workbook. It is not specific to breast cancer survivors, but it is the best book I have ever read on women's sexual health. It talks a lot about this dual control model, brake pedal, gas pedal, and then the workbook will actually walk you through identifying your brakes and your gas. I would say all of you read this. You and your partners, read it together. The author does a really good audiobook version of it. So listen to it in the car, and then together do the workbook. This brake, gas, ingredients impacts both of you. So this is best done together. Make this a conversation about, if your main desire is responsive, how can you two together get those ingredients in place? Okay, so here's the take home on low desire. There are 2 types of desire, spontaneous and responsive. With hormonal changes, responsive desire is going to be your predominant desire. So you got to maximize that responsivity, figure out what ingredients need to be in place, and really talk to your partner about these. Now let's go to the next one. We're going to go to sexual pain, and this brings us to Nancy. And Nancy says, we haven't had sex in 5 months. It hurts too much. I'm desperate. Okay, so let's just talk a little bit before we get into the specifics of Nancy's treatment. We'll talk a little bit about breast cancer and sexual pain. The sexual pain is typically caused by GSM, which I mentioned a little bit ago, genitourinary syndrome of menopause. The vulva and vagina, and I'm sure Shauna discussed this, but the vulva and vagina have tons of estrogen receptors. And when they're getting fed with estrogen, the vulva and vagina is nice and moist and plump, has good lubrication. The skin is elastic, so if there's vaginal penetration, again, it's more like a rubber band. The estrogen even helps facilitate blood flow to the genitals. And blood flow is a good thing when it comes to sexual arousal because that's how you get aroused. It's an increase in blood flow. So estrogen is great for the genitals. So when you don't have that estrogen, what happens for about half of women is they get GSM. The vulva and vagina dry out. You lose that elasticity, you lose that vaginal lubrication. There is less blood flowing to the genitals, which means it is more difficult to get aroused. The sensations are less. So maybe you're like, gosh, this used to work before, this used to get me aroused before, but now I don't really feel it as much. So sensations are less, and everything takes longer. It takes longer to reach orgasm. And then the orgasm you do reach, if you reach it, is less intense. And this is a result of hormones. And treatment-induced menopause is what causes GSM if you've had ovaries removed, if you're on chemo, if you're on aromatase inhibitors. So again, just like I said, caused by these things. And here's the thing, and I know Shauna discussed this to some degree, but induced menopause, where you just got thrust into menopause because ovaries were removed or because you got on aromatase inhibitors, is so much more damaging than natural menopause. It is like natural menopause on steroids because you've got this sudden onset, so the symptoms are much more severe, and these symptoms may not entirely respond to hormone therapy. Okay, so coming back to pain, and I mentioned this before, but estrogen is really helpful for the genitals. It maintains physiological function. It is critical in preserving all of these things, which I just mentioned a moment ago. And I know estrogen is kind of a 4-letter word, and we'll talk a little bit more about that, and Shauna talked a lot about that. Okay, so if you're having painful sex, what do you do with this? And the first thing I'm going to recommend is going to seem like I'm being rude, but I'm not. I'll explain why. So if you're having painful sex, step 1 is stop. Stop having painful sex. So many times I work with clients and they continue to have painful sex because they just think, well, you know, it should hurt a little, or it makes sense that it hurts a little, or maybe if we just keep going for longer, eventually it'll feel better. No, I mean, like I mentioned earlier, these sexual health symptoms will not go away unless there is treatment. So it's not just something to grin and bear. And here's what happens if you continue to have painful sex. It is incredibly damaging. This is what happens. Pain and sex get connected. So every time you think about sex, you think, ugh, that's gonna hurt. So sex, pain, sex, pain, sex, pain. Eventually these just get completely intertwined. So when your partner even rubs up against you, you think, ooh, my partner's initiating sex, and that's gonna hurt, I don't want it. So every time you have painful sex, you are just strengthening that connection that sex just equals pain, I don't want this. And then what this leads to is something called an avoidant dynamic. So I wanna explain an avoidant dynamic. So an avoidant dynamic starts like this. One partner says, oh, I don't wanna have sex because it hurts. Well, first of all, one partner initiates and the other one says, I don't want to have sex because it hurts. And then that partner initiates again, I don't want to have sex because it hurts. And then this partner goes like, well, you know what, I don't want to pressure you. I don't want to make you uncomfortable. I won't initiate anymore. You come to me when you want to have sex. Well, you're not going to because it hurts. It's just pain. So now nobody's having sex. Nobody's initiating it. Sex has stopped. And it has this really gnarly ripple effect. So sex has stopped. And then over time, there's a ripple to the non-sexual physical affection. So your partner comes up and hugs and kisses you, and you kind of flinch a little or pull away because you think, oh, are they initiating sex? So that non-sexual physical affection, that stops. Well, I don't want to go up and hug and kiss my partner because I don't want them to think I'm initiating sex, so I'm just not going to. I don't want to snuggle up against my partner at night because I don't want them to think I'm initiating sex, so I'm just not going to. So that non-sexual physical affection, that starts to decline. So now you're not having sex, you're not touching, and then over time, the last ripple is the emotional connection. And this is where couples come to me in therapy and they say, we just feel like roommates. So if you continue to have painful sex, that is a surefire way to get yourself into that avoidant dynamic, which then leads to that ripple effect of we just feel like roommates. So I know this first recommendation of stop seems so silly, but it is so important to stop connecting pain and sex. So the next step, is to see, is some low-hanging fruit, some over-the-counter options that could alleviate some of this pain? And I'll talk about these in a moment. And is there a different sexual menu? Maybe there aren't over-the-counter options to alleviate the pain, but perhaps there are different sexual activities you can engage in that aren't painful. And then the last step, I guess I'll get to the last step in a minute. So we'll do step 1 right now, or we'll do step 2. So over-the-counter options, moisturizers. So moisturizers are different than lubricants, and I'll talk about lubricants in a moment. Think about moisturizers as face cream for your vagina. So I'm sure most of us wake up in the morning and put on our face cream. I have my oil of Olay. So you have your thing, every morning you put on your face cream. This is the same thing as moisturizers. It's something you do every day. You have a routine. So maybe you do it right before bed at night, but you put your moisturizer on. And what moisturizers do is they trap in that moisture to allow your vaginal tissues to have that more moisturized barrier. And there's a cumulative effect with moisturizers. You can't just use them once and go, good, I'm moisturized. Same thing with putting moisture on your face. You can't just use it once and be like, good to go. It's something you do every single day, and it traps in that moisture. So it's just a daily way to feel more comfortable, for your vulva and vagina to feel more comfortable.
Question?
Yeah.
Do vagina moisturizers impact pH at all?
Ooh, good point. So this first moisturizer is Replens. Replens has some known irritants. It can impact pH, but there are some women who I've worked with who use Replens and say I'm totally fine with it. So there's gonna have to be a little bit of trial and error to figure out what is best for your pH. Hylogyne has specifically been developed for breast cancer survivors, but it's you have to order it from their website. So that's another really good option. But yes, there is it's gonna be annoying. There's some trial and error to figure out what is the best moisturizer for you, what doesn't cause any sort of irritation. Now the moisturizers are different than lubricants. Lubricants are as needed for friction reduction. So lubricants are in the moment. You put lube on yourself, you put lube also on your partner, you can make it a part of the sexual experience of, ooh, let's get the lube out, and we put a little bit on each other. So lubricants, there are a few different bases. There are actually lots of different bases, but I'm gonna share 2 of the more popular ones. There are water-based lubricants and silicone-based lubricants, and I'll share with you the difference. So a water-based lubricant, as it is, the base is water, and there's no contraindications. There's no reason that you should not be able to use a water-based lubricant. It really is a safe bet. The one bummer about a water-based lubricant is because it is based in water, it evaporates really quickly. So you'll be reapplying it frequently. What you can do, a little trick, is have a little glass of water by your nightstand, and you notice the lubricant getting a little dry, dip your fingers in the water, and then dip your fingers on the lube, and it'll reactivate it. Silicone is great because, so it's a silicone base. It does not evaporate. In fact, you'll probably have it on yourself longer than you want to have it on yourself. But it's great if you want to have sexual activity in the shower. It's just very long lasting, and it's incredibly slippery. So if you were to take silicone lube and just put it on the floor, you would legit slip and fall. That is how slippery silicone is. But sometimes that's the level of lube you need, so it's a good idea. But it has some contraindications. There are a few reasons why you might not want to use it. One is, if you're using it with any sort of sex toy or sexual aid that is also made of silicone, it can degrade. The 2 silicones, I don't know, something magical happens and the 2 silicones can degrade each other. So it could hurt your sex toys if they're made out of silicone. The second thing is, because it is so slippery, if your partner has any sort of erectile difficulties, it's gonna take away a lot of that friction for your partner, and they're gonna have more difficulty keeping that erection because it is so slippery. So a couple different options. Now let's talk about a new sexual menu. So maybe you're trying some over-the-counter options and they don't totally alleviate the pain. And I'm guessing for most of you, the pain is probably related to vaginal penetration. So could you create a new sexual menu that does not involve vaginal penetration? So consider a non-penetrative sexual menu. I have, and I'll give you the link later, but I have a link on my website where you can download a sexual menu, and it's 2-sided, and there's a scale at the top. And 0 is, I do not want to do this, and 5 is, I would love to do this. And then it's a bunch of lists of all different sexual activities. And you have one, and your partner has one, and you fill out, you rate them all the activities, you're interested in doing them, and then you compare your ratings. And then you can see, okay, is there a new menu we can create? There are also some online menus that are a little more advanced than the menu you can get from my website, mojoupgrade.com. So each of you get to log in and create a menu. We should try it.com. That one's a little bit more advanced, but I'll give you all the options. And then when you're thinking about your menu, also think about adding in a sex toy, adding in a vibrator. There's going to be a great breakout session later that talks about sex toys, but I want to just give a little summary of vibrators. And the reason why I'm suggesting vibrators is, I mentioned before that without all that estrogen, there is less blood flow to the genitals. And then as a result of less blood flow, you just feel less. There is less genital sensitivity. The things that used to work before are not working now to get you aroused. If there is less genital sensitivity, then you're going to need greater stimulation to feel what you felt before, which equals a vibrator. That's going to give you that more intense stimulation. With vibrators, here's what the research shows. 53% of women in their lifetime have used a vibrator, and that number jumps even higher if we're talking women who have had sex with women. So a lot of women have used a vibrator. I'm guessing that number might even be higher too. So these are two examples of vibrators. This one is just for clitoral stimulation. This is a silicone coating, and so just for the clitoris, it's just external stimulation. And this one is both can be put on the clitoris and inside the vagina, again has a silicone coating. These are by a company called Lelo, Lelo.com, which is kind of the, I don't know, like the luxury vibrators, but they're pricey. You don't have to get Lelo vibrators. I'm just using them as an example. But these are a couple different options. I'm just gonna say a little bit more about vibrators, but again, there's that breakout session later. They're really good for sexual satisfaction. They're good to facilitate blood flow. So here's the prescription. If you are interested in getting a vibrator, a sex toy, get something that is silicone. Silicone is the easiest to clean. Things like cyber skin or jelly rubber have all these nooks and crannies in them, and it's not possible to effectively clean those. So a medical grade silicone, like those Lelo vibrators, are great. I would recommend getting one that you can use internally and externally, so then you just have more options to try to see what you like. You can just clean it with soap and water. Do not share it with others. And then don't switch between orifices, so don't do anal stuff and then go to the vagina. Nope, just one orifice at a time. Okay, so last step, step 3, which Shauna talked a ton about, so I'm just gonna give kind of some brief info, is prescription options for GSM, genital urinary syndrome of menopause. So again, I'll go quickly because Shauna gave a ton of info, but I do want partners to hear this. There are treatment options for GSM. The kind of gold standard treatment option is that vaginal estrogen, which makes sense, right? You got all these estrogen receptors in the vulva vagina, they dry out, so how do you treat them? Give them estrogen. Estrogen helps increase blood flow to the pelvis. It increases that lubrication, that elasticity. It increases that genital tactile sensation. It doesn't mean that if you take vaginal estrogen, all of a sudden you're going to be like, oh, my vulva's like when I was 20 years old. No. But it's going to help things feel better, feel that tingly feeling again, feel those sensations again. There are creams, there are rings, there are tablets. Absolutely talk to your oncologist about options. And I want to just highlight what Shauna so really nicely said, is you may have an oncologist who says, oh, no, estrogen, not okay. What the research shows is that these localized estrogens, these estrogens that just go local, just go right to the vulva and vagina, minimally, if at all, get systemically taken up by the rest of the body. If they're local, for the most part, what the research is showing is that they stay local. So if you have an oncologist that just says, no, we can't even touch estrogens, I would either say, show me the research, or I would find a new oncologist. Have this conversation with your oncologist.
It's the low dose too, that's what I learned. It's the local and it's the low dose. And sometimes we even say it in the title, low dose estradiol.
Mm-hmm. Yeah.
I mean, that's such great information for us to have and to share.
Yeah. There are some other options too. These have not specifically been tested in breast cancer survivors, but they have been FDA approved, and I think these are worth conversations with your oncologist. And I cannot stress enough, and this was discussed in Shauna's talk, don't just take no for an answer. Advocate for yourself. If your oncologist is saying no, or I don't know, well then who do I talk to or help me find the answer? That's their job. So DHEA, progesterone, it's an intravaginal insert or suppository, and what it does is it activates the estrogen, androgen receptors. It activates those hormone receptors in the upper layers of the skin, called the epithelium, but not in other tissues. So it's not a hormone, but as it gets activated in your body, it essentially becomes a hormone. So it's a different way to get at it. The FDA has approved this for sexual pain. They have not yet specifically approved it for breast cancer survivors. It is still worth a conversation with your oncologist in case you're interested in something like this as an alternative to vaginal estrogen. Very similar, ospemifene, not an insert, not a suppository, it's a pill. It's a SERM, which is a selective androgen modulator receptor, but it acts similar to estrogen on the upper layers of that skin, the epithelium. It has been FDA approved for sexual pain and vaginal dryness, but not yet approved for those with breast cancer. But again, if you're thinking, I just don't know if I want to introduce hormones, these are other options to talk to your oncologist about. And let's talk about vaginal lasers for a moment, because I often get a lot of questions about that. So vaginal lasers, and this is a side view. This is the vaginal canal, and this is the laser going in the vaginal canal. So here's what the vaginal laser does. The laser actually creates microcuts. It injures the tissue in the vagina with the idea that it will encourage healing of healthier tissue. But there was a study done in 2021, 85 women came in, and half the women got a legit laser, and half the women were given treatment with a fake laser. And when they did a follow-up, they found absolutely no difference in treatment outcome. Meaning women with the fake laser, they reported no different symptoms or benefits than women with the real laser. And so as a result of that, the FDA warns of the risk of adverse events with something like this, with using a vaginal laser. So here's the take home on sexual pain. It is caused by treatment-induced menopause. Number one, stop having painful sex. 2, think about some low-hanging fruit like over-the-counter behavioral options, moisturizers, lubricants, maybe a new sexual menu, maybe bringing in a vibrator. And then consider prescription options. And I'll go back to this and talk to your oncologist, because there are options. And if they say no, then say, give me the research or refer me to someone else. Okay, poor body image. And how are we doing on time? 12 more minutes? Okay, we'll see what I can do in 12 minutes. 22? Okay, 12 to 22 minutes. I got this now. Okay, so this is Kelly. Kelly says, I can't even look at my breasts, let alone let my wife look. I haven't let her touch me since my surgery. So if any of you are reporting feeling different about your body image, pay attention to Kelly. So let's talk a little bit about breast cancer and body image. It is hard to be sexual if you don't feel sexy, or if you don't think that your partner is going to find you sexy or find your breasts or your chest attractive. And these negative thoughts are incredibly distracting. You know, I mentioned several times before that I ask my clients, when you're actually having sex, what are you thinking about? And with my clients with breast cancer, they say, I'm just thinking about how this doesn't feel the same and how this looks gross. And there's no way my partner could be attracted to me. And if that's what's going through your mind during sex, yeah, you're not going to get aroused. You're not going to have desire. Mindfulness is the treatment for this. And Shauna brought up mindfulness as well. Mindfulness is the ability to be fully present in the moment without judgment. It's also called non-reactive awareness. It's a being aware of whatever is happening in the moment, but not reactively. And it's been shown to improve your sexual desire. So this research has been done specifically with breast cancer survivors. It has improved sexual desire, sexual arousal, and even reduced sexual pain, being mindful during a sexual experience. And being mindful is, so imagine you're in the moment, and we're gonna do a mindfulness exercise in a moment, but you're in the moment and you're just attending to what's ever happening in this exact moment. How does your butt feel on the chair? How does your hand feel holding this pen? And maybe a thought comes in and you think like, this is stupid, when's she gonna be done talking? You just let that thought go by. And then all of you laughed a little too much on that one. You just let that thought go by, and then you just go right back into the moment of how you're feeling in the present moment. So that's that non-reactivity, that a judgmental thought may come in, you wave hi to it, you go, oh, I see you thought, you're just a thought. You let it go by, and then you get right back to what you're feeling in that moment. And again, we'll do an exercise in just a moment so you can feel what mindfulness feels like. You can do mindfulness solo or with a partner, which is great. It's such a versatile activity. And you could do it anytime. So what I'm proposing that we're going to do now is to start it non-sexually. It'd be really difficult to try to be mindful for the first time in a sexual experience. So let's do a little activity where you're doing it non-sexually. We're going to do a 3-minute exercise. So what I want you all to do is grab something, anything. It could be your water bottle, your phone, a pen, your piece of paper. It does not matter what you grab, but grab some object. And so I'll do my remote. So everyone have an object? Looks like it? Okay, so I want you to take this object and just, I don't know, it may not fit in your hand, but if it does fit in your hand, just put it on your hand and I just want you to observe it. And in your mind, just describe factually what you see. And here's a really important thing, factually. So if I look at this remote and I go, it's kind of ugly, that is not a fact, that is a judgment. So factually, in my mind, I'm saying, well, it's black, it is kind of rounded on the edges, just a fact. If you're a video camera, what would you see? Describe it factually. So take a moment and do that just for a moment, and then we'll continue with it. So factually, describe this. How does the light bounce off of it? What is the weight of it? Is it heavy? Is it light? What do the edges look like? The colors, do the colors change throughout? And then when you're ready, I want you to just take a finger, a couple fingers, and touch it. What does it feel like? Factual, just factual. Like I feel this remote and I go, okay, it's smooth. It's kind of bumpy here. There's like I feel a dip. So just factually describe what this item feels like on your fingertips. Just facts. And if you notice any judgment, let it go by. Get right back to the facts. What does it feel like? Okay, so next is I want you to smell it. So take this object and start it just with one nostril. Beginning, middle, and end, what's that smell like? And then go to the next nostril. Beginning, middle, and end. Is there a different scent beginning, middle, and end? Does it differ from nostril to nostril? Just factual. What does it smell like? Now next, I want you to take it and put it next to each ear. And maybe roll it around in your fingers if you can. What does it sound like? And go to the next ear. What do you hear? And for me, I hear kind of like a clicking. What does it sound like? And then we're going to do one more. If you feel comfortable, I don't know what object you chose, can you put it up to your lips? What does that feel like? I mean, you can put your tongue on it if you want. I don't know. Is it soft? Is it rough? Okay. So that was about 3 minutes. That's mindfulness. Mindfulness is being completely absorbed in the moment with whatever it is, without judgment. Just like you're a video camera, you're just factually describing all the observations and sensations. Now, I mentioned here a mindful eating exercise because typically a great way to start learning mindfulness is with a piece of food. So we did it with an object, but if you were having lunch right now, I would have asked you to take a bite of food and you would have eaten the food and slowly chewed it and put it in between your teeth, and we would have done 10 minutes with one bite of food, but we just did an object for 3 minutes today, just for you to get an idea. Headspace is a really great app to do mindfulness exercises. And then here's what we know from the research. Mindfulness body scans are most impactful when it comes to breast cancer and sexual health. So what you just did to this object, imagine if you just did this to your body for 20 full minutes. So if you started at the top of your head and just scanned, what does it feel like? All the sensations, and then went down to your face and your chin and just went all the way down your body for 20 full minutes, top to bottom, and just scanned all the sensations. And judgment's gonna come in. When you get to your breasts, absolutely there's gonna be judgment. And then judgmental thought comes in, and you go, hello, goodbye, and then you get right back to factually describing, okay, this is cold, this feels hard, this is bumpy. Factually describing. It allows you to be neutral with your body. I mean, a lot of clients I see say, I want to have body positivity, and that's a great and aspirational, but if we think about this as a continuum, over here is body positivity, over here is body negativity. I just want you all to get to neutral. Can you be neutral with your bodies? And then later you can work on the positivity piece. Mindfulness is so powerful to just be neutral with your body, to not be beating yourself up every time you're connected with your body. So what the research shows is the maximum benefit of mindfulness is a body scan 20 minutes a day. And there are partnered exercises that are very similar to body scans, but with partners. I'll talk about those in a little bit. This website, loribrado.com/mindfulness recordings. So Lori Brado is a psychologist who has done all of this research on mindfulness, sexual health, and breast cancer survivors. She is the one who's done this all. And her mindfulness recordings are free online on her website. So if you're interested in doing body scans or shorter, even shorter, small mindfulness exercises, go to her website and download those recordings and try them out and see what it feels like for you. She has also written 2 books, Better Sex Through Mindfulness, and then recently a workbook came out that she wrote. I'll be honest, I love Dr. Brado, and this book was really boring. So I would say just get the workbook. You don't have to have the book, but if you want to know all like the academics and the research behind it, then absolutely get the book. But if you're like, I just want to learn mindfulness for better sexual health, then just get the workbook. Headspace, Andy Puddicombe is the man who invented Headspace, which is a really great app to learn mindfulness. And he's got a 10-minute TED Talk. If you want to learn more about mindfulness, it's worth a 10-minute watch. And then here's his app, Headspace, where you get 14 days free, so you can try it out. And it's just little mindfulness activities on your phone, so you can try out mindfulness. Okay, and last, we've got the avoidant sexual dynamic. So to talk about the avoidant sexual dynamic, I've got to return to that circular sexual response model in a moment. So your sexual relationship, your sexual response cycle, like the circular one, may differ from your partner's. So partners, I want you absolutely tuning in to think about what your cycle is. We talked about this one before. For most of the women in this room, maybe you'll sometimes have spontaneous desire, but mostly it's going to be that responsive desire that's going to allow this cycle to continue. And again, arousal's got to come first. Your body has to be feeling something for then your mind to say, oh yeah, I'm kind of into this. So for most of the women in this room, this is going to be how your desire works. For the partners, more than likely, this is how your desire works. This is called the linear model. It starts with desire, I want to have sex. Then the body gets aroused, then sexual activity happens, there's orgasm, and then the resolution phase. You see these 3 different lines here just because there are 3 different types of orgasms. For some people there's one big one, for some there's multiple, for some there's just like one long little one. It's not totally relevant to this. What I want you to take from this is, if your main model of desire, the way you approach desire is spontaneous desire, then you're working from this linear model, which means desire just comes out of the blue. You're like, hey, I want to have sex. I spontaneously want to have sex. Body gets aroused, reach orgasm, which is very different from the circular model. The circular model is be responsive, get all those ingredients in place. Then there's stimuli. As long as everything's in check, then your body has to get aroused, and then there's desire. They're very different models. And oftentimes when I'm working with heterosexual couples, the man is like, who's got this model, spontaneous, he's like, why doesn't she want me? Why isn't her desire spontaneous? Clearly she doesn't want me. No, it's just that her model of how she responds is different. Ingredients have to get placed, things have to get kick-started. The way I describe this is, this model, the spontaneous model, is like a microwave. You just put the food in, beep, 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 it is hot in like 30 seconds. And this is a crock pot. What ingredients need to be put in place? And they've got to simmer. So when partners have different types of desire, it can be confusing, and wait, you don't really want me, and but wait a second, they're just different. So how can you 2 talk through this and figure out what works for both of you? Okay, so your sexual response cycles may differ, and your partner may not understand that your sexual response is responsive. So talk with your partner about the ingredients you need to have in place to be responsive. Emotional intimacy is one of those key ingredients. And then for those of you where your main desire is responsive, it has to be kickstarted with arousal. So you may say like, I could be open to it, I don't know, I might be open. Okay, well what helps kickstart your arousal? Is it a massage? Is it kissing? Is it naked snuggling? But what kickstart your arousal? Now, what if you're in an avoidant dynamic? What do you do? Because you may sensate focus exercises. These are the best exercises. These are the exercises I walk my clients through when they come in my office and say, we just feel like we're roommates. We're in that avoidant dynamic. These are exercises there's no demand, there's no pressure, they're just touching exercises. And they're called sensate focus because they're about focusing on sensations. These are mindfulness exercises, essentially. These are not sex, you're just touching. So let me give you the basics, and you can download the first phase of sensate focus free on my website. I'll give you the link toward the end. So this is a touching exercise where you have some private space with your partner and you set aside 20 to 30 minutes. If that feels like too much, set aside 10 minutes, just some number of minutes. So you set aside 20 to 30 minutes and you're giving each other full body touch. You are nude to whatever extent feels comfortable. If you say being fully nude is gonna make you really anxious or uncomfortable, then put some clothes on, whatever will help you feel comfortable. No sexual activity is allowed, and this is so incredibly important because if you think that these touching exercises are basically just foreplay to sex, you're gonna go like, no, I don't wanna do this. So you both agree, these cannot lead to sex, these are not sex, this is just touching. And ideally, you do these exercises every 48 to 72 hours to keep the momentum going. And there are phases, each phase builds upon the next. I wanna describe the first phase. So in phase 1, full body touching. No touching of breast, chest, or genitals in phase 1. Those traditionally more kind of erogenous zones are off the limits, off the table. Just to get you getting more creative, touching all of the body. Oftentimes when I work with couples and they do a touching exercise, they go right to like genitals. And I'm like, no, there's all the rest of your body. Touching between the toes, behind the ears. And what's also nice is if you're not feeling comfortable with your breast or chest, it's off limits this first time around. It's off limits. No sex, I can't express that enough. These are nonverbal, these are mindfulness exercises. So you're not talking during them, you're just touching. You take turns, so if this is 30 minutes, for 15 minutes your partner touches you, and then you say switch, and then for 15 minutes you're like, can I use my tongue? No, hands and fingers only. These are not sexual. And now here's a super important piece. You are touching for yourself. So many people do these exercises wrong because they think, oh, these are like massage exercises and I'm trying to figure out what's gonna please my partner. No, this is not about pleasing your partner. You are touching for yourself. So let me explain this. When you're touching, you're focusing on 3 sensations: temperature, pressure, and texture. So imagine you're touching your partner. Is this warm, is this cool? Pressure, is this firm, is this soft? Texture, is this rough, is this smooth? TPT. You are focusing on temperature, pressure, texture as you touch your partner's body. You are not trying to massage them. You are not trying to please them. You're not trying to get them aroused. You're not trying to get aroused. This is just a mindfulness exercise. Just like I described that body scan, that solo body scan, this is basically a partnered body scan. These sensations are always there. They're vivid, they're reliable. That's what you focus on. You focus on TPT because there's always going to be TPT. Here's where you can download the exercises, the first phase from my website. It's also attached to a sexual menu, so those come in a combo. And then this book, Sensate Focus in Sex Therapy, it's mostly written for therapists, but it really walks through all the phases of Sensate Focus if you want to learn more about it. Okay, you may need sexual arousal to kickstart it. Emotional intimacy is one of those necessary ingredients. If you're in an avoidant dynamic, think about Sensate Focus. And if you're kind of liking the idea of Sensate Focus, you might want to work with a sex therapist to help guide you through that. The best place to find a sex therapist is asec.org, American Association for Sex Educators, Counselors, and Therapists. There are over a dozen of us in the state of Utah of certified sex therapists. You can also find some at ISHWISH, but ASEC is going to be your best bet. Overall take-home message, breast cancer does not take away your sexuality. Maximize your responsivity with the right menu. Talk to your doctor about GSM, and if you're in an avoidant dynamic, consider Sensate Focus, consider sex therapy. Thank you so much.
That was awesome. Thank you so much.
Thank you.
Any questions for Dr. Rullo? Yes, ma'am.
What resources would you suggest for male body image issues?
Ooh.
What was the question?
What resources would I suggest for male body image issues? Gosh, you know, that's such a good question. So I don't have a good answer for you. There has not been research done on men and mindfulness and body image, but I have no reason to believe that mindfulness wouldn't be as beneficial for men as it would be for women. So I would almost want to start with a mindfulness book, even Lori Brado's mindfulness workbook, as a way, again, to build that neutrality, regardless of gender. It's a great question.
I have a question for you. I still see a lot of breast cancer patients, and some bring social media into the discussion, for breast reconstruction.
Yeah.
And how do you manage this in your practice? Because nobody shows anything bad at social media. They're all beautiful, they're all amazing, life is wonderful. How do you deal with your patients?
Yeah, part of it is the type of therapy I do is something called cognitive behavioral therapy, but CBT is about identifying what your thoughts are in that moment. So when you see that social media image, what are all the thoughts? How are you interpreting that? Are you interpreting that as, this is how I should look? This is the ideal. I won't find a partner if I don't look like this. Or my partner won't love me if I don't like, what are all those thoughts? And then we first identify those thoughts, and then we start to look at them and say, how accurate are these? How rational are these? And then we break them down and start to challenge them. So I do CBT, and then what I'd also do is I'd say, get off social media, get off it.
Questions?
When you don't have the feeling sensation after a mastectomy.
Yeah.
That, and I mean, that may have been a part of your relationship before, and then after trying to regain that, it's like there is no feelings, you never know, it's
Yeah.
just a weird.
Yeah, and that's such a good point. So she just said when you don't have those feeling sensations after mastectomy, that you just lost all that. And a lot of times what couples will describe is because in a neutral way with mindfulness, you're able to start to explore, okay, are there other parts of my body that feel, like how do they feel, that I'm interested in being touched more? Like there needs to be an exploration and getting a little bit more creative of, are there other parts of your body that you could tap into that feel good, that could kickstart that arousal? But like it's an absolute loss. It's an absolute loss. Yeah.
Well, I thank you again. Thank you for coming back. There'll be some workshops that will be kind of continuing.
Yes.
Stephanie is doing a workshop on intimacy. You are doing a workshop. And I'm going to bring Allie here to talk about the program for this afternoon. Thank you again, Dr.
Yeah, thank you. Thanks for having me. Okay, thank you everyone for being here. I'll tell you a little bit about just my background. So I'm a clinical health psychologist, I'm a certified sex therapist, but I'm a certified Gottman method couples therapist. And I actually only see couples. So in my private practice, I only work with couples whose main concern is a sexual health related concern. So I want to tell you what Gottman is, because that's what today is going to be entirely about. It's going to be about Gottman. How many of you have heard Gottman couples therapy, John Gottman? Raise your hand. It's like a tentative hand over here. Okay, so very few people. Okay, neat. Well, I'm going to introduce you to some amazing stuff. So John Gottman, Gottman's just his last name, but he's a couples therapist, a psychologist, and then his wife Julie Gottman, the Gottmans. She's also a psychologist, couples therapist. They have been doing research on couples therapy, couples interactions, couples communication for 40 plus years. And Gottman even created this thing he calls the Love Lab. It was really innovative, but he's in Seattle and he got this apartment and hooked it up with all these different video cameras and would invite couples in for a weekend to just live in the apartment. In return, he would gather all this data, recording them. And he was watching how do couples interact, what leads to an argument, what doesn't lead to an argument, when couples are happy, what makes them happy, when couples are unhappy, what makes them happy. And so this is what all of his research is based on. So these are all research-based, evidence-based techniques to be able to communicate with your partner, which is so important during a time like surviving through breast cancer and recovery after breast cancer. So I'm going to teach some of these main Gottman skills today. Does everybody, see you don't have a partner, is your partner en route? Okay, so just called her out. I feel bad for her. She's been called out. Okay.
She's manning the table back there, but she's...
Okay, good, so you're partnered. Let me get you a handout.
That's your first, that's proof.
Okay. I just want to make sure, okay, so everyone's got a partner. Good. So what I'll be sharing with you today, and this is going to be a super interactive session, you're going to learn 4 Gottman skills to improve your relationship during your breast cancer journey. And even if your partners aren't here, if you're paired up with someone who's not your partner, you're still going to learn this skill. This is going to be super interactive. We're going to have a couple exercises. Each exercise is going to be about 20 minutes, and there's going to be one exercise to take home that you'll be doing at home. Find a partner. That already happened. Great, we did this. Grab a handout. Does anyone not have a handout? This is the Lean On Me handout. Excellent. Everyone's got the Lean On Me handout. So before we start doing these exercises, I want to just share just a little bit about breast cancer and couples. In the research, they call this a we disease, because breast cancer does not just impact one of you, it impacts both of you. You cope with cancer as a team, not as an individual. And what the research consistently shows is that partner support. When your partner supports you during this journey, your cancer outcomes improve, your pain during this journey is less, and mortality is lower, just from having your partner support during this journey. And research also shows that a resilient relationship helps you better navigate your cancer journey. So how exactly do you get resiliency? How exactly are resilient couples resilient? Well, here's what the research shows. How do you get resiliency in your relationship? 3 things. You and your partner emotionally support each other. You communicate with each other through this time, and the way you both cope, you cope in a way that's shared. You have shared coping strategies. We're gonna go through each of these specifically. So let's start with emotional support. And this is what I hear so many of my clients say, especially as they're going through this breast cancer journey. You're just trying to get through the day. Sometimes your ship's passing at night because you're trying to navigate just the household and kids, but then also cancer treatment. Maybe you're both on your cell phones, like you're just fried, so you're just on your phones, you're not paying attention to each other. Maybe you're even sleeping in different bedrooms because one of you just can't get good sleep when the other one's in there. So how, especially during this time, do you emotionally support each other? I want to share something, the first Gottman concept, which is called turning towards instead of away. This is so incredibly important and helpful. So couples interact through something called bids for connection. And a bid is, it's a gesture, it's either verbal or nonverbal, but you're basically reaching towards your partner, turning towards your partner to connect with them. So let me give you examples of bids. A simple bid would be, maybe your partner gets home from the day and you say, oh, how was your day? That's a bid, that's a verbal bid. How was your day? Maybe you two are hanging out and you go like, oh, look, it's sunny outside. That's a verbal bid. Nonverbal bid, maybe you snuggle up next to your partner and they snuggle back. That's just a nonverbal bid. You are turning towards your partner to try to connect with them, whether verbally or nonverbally. What the research shows is that happy couples respond to their partner's bid in a positive way. They turn towards their partner's bid. So, how was your day? Oh, it was pretty good. Or, oh, my day was so hard. Or, look, it's really nice outside. Yeah, it is really nice outside. So that's responding positively to your partner's bid. Happy couples do that. They turn towards each other. Now here are examples. I gave you a few, but I'll give you more examples of bids. Your partner tells a joke. Maybe it's not that funny. You still respond to it. Maybe they say like, I can't find my keys. And then you're like, oh, okay, jump to action. Where did you last leave them? You're helping them solve a problem. Maybe you show active interest and excitement in their accomplishments. Like, oh, I did a project today and it went really well. And you're like, oh, that's awesome. Tell me about it. That's you responding positively to their bid. Just paying attention to what they're saying. I mean, think how often you're talking to your partner and you're like, honey, are you even listening? Are you even listening? So just pay attention to what they're saying is positively responding to a bid. Now the other way you can respond to a bid is to turn away from a bid. So turn away with disinterest. Maybe you're glued to your phone, your partner's talking and you're not even paying attention because you're just on your phone. Or maybe they're talking and you're just not interested in what they're talking about, so you're doing something else. Or maybe they're talking and you're just mindlessly saying like, okay, yeah, I've heard this before. Or even worse, you can turn against them. You know, I don't have time to talk with you. Or, yeah, what do you want now? Or I've heard this before, can you be quiet? So you can turn towards your partner, you can turn away and just be disinterested, you can turn against. Those are your 3 options to respond. Now these bids, whether they're verbal or nonverbal, they fill what Gottman calls the emotional bank account. So every relationship has this hypothetical bank account. And this bank account, whether you're running a deficit or a surplus, determines how connected you feel in your relationship. And it's the bids that fill this bank account. So a relationship bank account, the balance determines how safe, how secure, how connected you feel in your relationship. Here's what the research shows. I think this is so fascinating. I don't even like math. When you turn towards your partner, it is a $1 deposit in that bank account. So, hey, honey, how was your day? Oh, it's pretty good. $1 deposit. When you turn away from your partner, it is a $5 withdrawal. Hey, honey, how was your day? I don't want to talk about it. Or, oh, this really cool thing happened, and you're just on your phone. every time you turn away from your partner, whether it's just a simple turn away because you're just not interested, or a turn away against them, like I don't want to hear about it, that is a $5 withdrawal from that bank account. And what the research shows is that happy couples are turning towards each other every 5 times, that they're just turning away from each other every 1 time. So it's a 5-to-1 ratio. They're doing 5 turn towards, 5 deposits for every 1 withdrawal, which basically just gives you 0 in the bank account. Because if you do the math, 5 turns towards is $5. 1 withdraw is minus $5. You at least just have 0. Your bank account's at least neutral, but neutral is fine for happy couples. So I took a lot of time to make this graphic. I want to show you this graphic. There is a $1 deposit, 1 turn toward, but then let's say your partner turns away the next day, bam, $5 withdrawal. So it really takes a hit. A turn away really takes a hit. Okay, so emotional bank account is filled with these bids. When you turn towards, it's $1 in the bank. When you turn away, you take $5 out. So how do you not run a deficit in your bank account? Turn towards your partner. It's that simple. Turn towards them when they put out a bid. So I have, it's for you to download, a turning towards exercise that I'd love for you to do at some point today or just when it's still on your mind. You can download it here. That's my website, and then just /turning towards. But this is the at-home exercise I want you to do. But really, as you go home, or even today throughout the conference, every little thing your partner does to bid for you, to turn towards you, to connect with you, to talk with you, to reach out to you, think in your mind, oh, that was a bid. Maybe they send you a random text in the middle of the day, and the text doesn't even need a response. Maybe the text is just like thinking of you, and you're like, I don't need to respond to that. That was a bid. Just respond back with a heart emoji. All of these are so many opportunities to put little bits of money in your bank account. These are all bids. And maybe you find maybe you're like, my partner often dismisses my bids. Tell your partner, say, hey, that was a bid. Like, you've learned this lingo now. Tell your partner, hey, that was a bid. And that might be an idea of like, oh, that was a bid. Okay, I want to turn towards that. But use this language, hey, that was a bid. And then when you do this exercise at home, and both of you download the sheet and do the exercise, then share it with each other. Okay, so that was the at-home exercise. Now we're going to go to some communication. And this is, again, resilient couples. These are the couples that support each other through this cancer survivor journey. Resilient couples communicate. So I'm going to teach you some really awesome, I think they're awesome, Gottman communication skills, and then we're going to do some exercises with these. So we know that open and shared communication about what you're afraid of, what you're worried about, and what you need means you're going to cope more successfully together. You're going to have better relationship satisfaction. This is what all the research shows. So how do you do it? How do you talk about these fears, worries, and needs? Because that could be hard and it could be vulnerable. The first, this is the second skill I'll be teaching today, but the first way to communicate about these hard things that you're afraid of or you're worried about is something called a softened startup. So a softened startup goes like this, and this is the top of your handout because this is the first thing you'll be practicing. I feel, and it's just a one feeling word. About what, you describe a situation, just the facts of the situation, and I need, a positive need. So let me give you an example of this. I feel lonely. And actually, I think the example's next. So I feel lonely. Lots of couples get tripped up with this one. And they say, I feel you're being a jerk. No, that is not a feeling. It starts with I feel, and a feeling is typically just one singular word. I feel, what's the one word? So lonely, this is the example. And then about what? So that I'm going to my doctor's appointments alone. Now this is where it's really important that you describe a situation, just the facts. So a lot of times people will say, okay, well I feel lonely because you're being so selfish that you're not coming with me to my appointment. Nope, you've just put an opinion in there, just the facts. The facts are, I'm going to my doctor's appointments alone. Factual. Don't attack anyone, don't blame anyone. I'm going to my doctor's appointments alone. So I feel lonely that I'm going to my doctor's appointments alone, and I need, and this is where it's a positive need, and I need you to come with me to the more important appointments. A positive need is telling your partner, this is what I need you to do. A lot of times what couples do is they tell your partner, I need you to knock that off. I need you to stop doing this. Okay, but you're not giving them an information on what they can actually act on. You're just telling them what not to do. So a positive need is telling them what you need them to do. You're giving them the information of this is what I need you to act on. So I feel Just one word, about what, you just factually describe what it is, and I need, a positive need. Now this is called a soft startup. The alternative to a soft startup is something called a harsh startup. And pretty much 100% of the time, a harsh startup starts with you. You never go to my doctor's appointments. I feel you never go to my doctor's appointments. Nope, that's not a feeling. So you never come to my doctor's appointments, and I'm tired of it. Well, your partner has no idea what your need is. They don't know what they can act on. You're not setting them up for success. And from the moment of you, as soon as you hear you, you're like, those are fighting words. I'm ready for this. So instead, I feel lonely that I'm going to my doctor's appointments alone, and I need you to come with me to the more important ones. Now here's what the research shows. The first 3 minutes of a conflict discussion predict how it's going to end with 96% accuracy. So why this is relevant? If the first 3 minutes of a conversation you have with your partner starts harshly, you never do this, you don't do this. If the first 3 minutes start harshly, there is a 96% prediction that it is going to end harshly. So how you start a conversation massively impacts how that conversation is going to go and how it's going to end. Now let's say you do this off in startup and you tell your partner how you're feeling about what and what you need, then what does your partner do? Well, this is where something called the Gottman-Rappaport comes in. Back this up for a second. Gottman-Rappaport, this is super neat. So Gottman, I've already introduced you to Gottman. Well, who is Rappaport? So Rappaport is this guy, I believe he was a social psychologist, and he specialized in how countries at war negotiate during the wartime process and effectively negotiate. So he came up with these communication tactics and determined, okay, this is a much more effective negotiation strategy or discussion strategy. And then Gottman went and took his strategies and said, oh my gosh, we can use these warring country info with our warring couples and help them find a way to talk to each other. So that's why this is called the Gottman-Rappaport. It starts with, so let's say your partner starts with the soft startup, they tell you what they need. You reflect what you heard from them. So I just heard you say, that you're lonely and that you're lonely and you want me to be coming to more of your doctor's appointments, more of the important ones. And then second, you check in with them. Did I hear that correctly? Then third, a validating statement. Now this is so important. So many couples miss this. It makes sense that you feel this way and why it makes sense. This is where couples miss this. Validation is so important. You know, it makes sense that you're feeling lonely because I'm not coming with you to most of your doctor's appointments, and I know they're really stressful. When you validate, that doesn't mean you agree, because you may be sitting here going, I have come with you to most of the doctor's appointments. I do not agree with that. Zip it. Just put yourself in their shoes. Their perception is you're not, their perception is they're lonely. Can you validate that? Does that make sense? Even if you don't agree with it, even if your reality is different, can you try to sit in their reality and say, okay, you know, it makes sense. If you feel like you're alone at these appointments, I could see how you feel really lonely and you want me to come with you to them. So validation is so important, and that doesn't mean you have to agree with the person. So here's the example. I hear you say that you feel lonely because you're going to your doctor's appointments alone. Did I get that? Yes, you did. And it makes sense. You feel lonely because you have been going to these alone and they're really stressful. So that's the Gottman-Rappaport. And this, you can download this. You have a digital copy of this at my website too, but all of you have a paper copy right now. So now we're gonna practice this. So everyone's got your pairs, excellent. One of you is gonna be the speaker and one of you is gonna be the listener. So the speaker is going to start with the softened startup. I feel about what and I need. And then the listener is going to jump in with the Gottman-Rappaport. They're going to summarize what they heard the speaker say. Check in, did I get that? And then try to do a validating statement. So we're going to do 8 minutes of this Gottman-Rappaport where one person is the speaker, and then we're going to switch, and 8 minutes where the other person who was the listener now becomes the speaker. So in total, this is about a 16-minute exercise. Okay, let me put this on the screen so you can see this. So again, decide who's going to be the speaker. The speaker is going to start with a soft startup. Then the listener is going to respond with what I just heard you say. Did I hear that correctly? It makes sense that you feel this way because. All right, I see a lot of confusion. Tell me your questions. What questions do you have?
What if you really have been going to the doctor appointments every time?
Oh, this is just an example.
I know,
Yeah.
I'm just saying.
Yes.
When they say something and you're supposed to say, it makes sense, and it doesn't make sense.
Yes, okay, okay, good point. There's a couple things here. Like in an actual couples therapy session, and we might have a little bit of time to do this. If you are really like, I don't get what you're coming from, I'm not coming to every appointment, then ask them, but not in a blamey or accusational way. Just say like, I'm a little bit confused. Help me understand why you feel like I haven't been coming with you to your doctor's appointments. Help me understand. If you can genuinely approach your partner with curiosity, help me understand why you feel this way, then that might help you validate. And maybe they'll go like, well, I guess when I look at the calendar you have, but I don't know, I just feel so alone in the appointments. Maybe if you took notes during them or we debriefed afterward, or I don't know what will come out of that, but if you are like, I cannot validate this, this doesn't make any sense to me, then ask a curious question. Get curious, help me understand. You two are teammates in this, so if you don't understand what your partner's saying, ask. And then let's say you ask and you still don't get it, you just have to dig deep and do your best validation.
I ask, it comes across as conflict, like I'm accusing.
Good point. So this is where you could say like, hey, I want to do it like we learned. Can we pull our sheets out? I'm going to do my best because I really just want to try to understand you. I really want to try to hear you. And so both of you are coming up a mind space of like, okay, we're trying to learn a new skill. We're not trying to attack each other. Let's see if we can try this.
That's what I was trying to say. It comes across as attacking.
Yeah, and you can really be like, I really want to learn this skill with you. I really want to make this work with us. Other questions before we get started? Okay, so decide who's the speaker, and I feel about what I need, and I'll be walking around to help people. And take another 30 seconds. Does anyone have any questions before we go to the next exercise? Yes.
So we're not supposed to solve each other's problems or solve.
Ooh, okay, great question. So the question is, so we're not supposed to solve each other's problems. That question came up over here too. So here, okay, there's a couple ways to answer this. Absolutely, you're not supposed to solve each other's problems. That's just a hands down. Actually, our next exercise is going to be about that, not trying to fix your partner's problems. So you're not trying to solve your partner's problems. The whole purpose of this exercise, the Soften Startup and the Gottman Rapport, is just having a safe space to share with your partner how you're feeling and what you need to truly be heard. So you get heard, your partner gets heard, and then after you both are fully heard on a topic, then the next step is, okay, we both heard each other. Are you up for problem solving this? And then you're problem solving it as teammates. I hear where you're coming from. I hear where you're coming from. I hear your needs. I hear your needs. Now let's see, can we solve this problem in a way that both of our needs can get met? So yes, as you're talking, don't solve anything. Just hear each other. Just hear each other. Then after you're both heard, then problem solve. And that's what Rappaport learned. These warring countries couldn't get to a good resolution until they totally heard each other. Once they totally heard each other, then the foundation was laid to say, now we can start to solve a problem.
So if one of us has an issue and I bring up the soft start,
Yep.
I should then let the partner
Exactly.
have a turn.
Yes.
That's where we probably don't do that second part. If whoever brings up the issue or whatever,
Yep.
then the other person's usually just silent.
So I just want to repeat the question. So if one person has an issue, you state out your issue and then give the other person space to say how they feel about that issue. It's not just, hey, I got this issue, and the other person's like, oh. No, you both get the opportunity to say how you feel about the issue. Because it's probably an issue because you both have different ideas, opinions, and needs around it. That's probably why it became an issue in the first place. So yes, you both get the floor to be heard on an issue, even if only one of you brought it up. Great question. Okay, so we're going to go to the next exercise. This is shared coping strategies. Again, the research shows that if a couple has shared coping strategies, they're much more resilient during this time. What we know about coping strategies in the research is that women are more likely to experience or express negative emotions. They're more likely to experience or express, especially express anxiety, depression, express their stress, whereas men are more likely to problem solve. I want to protect you from that pain. I'm just going to want to fix it. So this, I'm going to show a video in a moment. Oh, so before I even get to that, what we call this in couples therapy is a meta-emotion mismatch. So meta-emotions are your feelings about emotions. And some people might say, oh yeah, I feel like we need to get our emotions out, we need to process them, we need to talk about them. And some people might say, emotions, it's a waste of time, let's just fix it, let's just get it done. And when there's a mismatch, when one of you wants to express and feel emotions and process them and the other just doesn't want to feel them and just wants to fix it, that's a meta-emotion mismatch. So in couples therapy, to have shared coping, you want to get a match, you want to get a meta-emotion match. This is a really great video that shows a meta-emotion mismatch. It's about a 2 to 3 minute video, so I'm going to play this. Hopefully it'll play.
It's just, there's all this pressure, you know? And sometimes it's right up on me, and I can just feel it, like literally feel it in my head, and it's relentless. And I don't know if it's going to stop. I mean, that's the thing that scares me the most, is that I don't know if it's ever going to stop.
Yeah. Well, you do have a nail in your head.
It is not about the nail.
Are you sure? Because, I mean, I'll bet if we got that out of there...
Stop trying to fix it.
No, I'm not trying to fix it. I'm just pointing out that maybe the nail is causing...
You always do this. You always try to fix things when what I really need is for you to just listen.
See, I don't think that is what you need. I think what you need is to get the nail
See, you're
out.
not even listening now.
Okay, fine. I will listen. Fine.
It's just, sometimes it's like, there's this achy, I don't know what it is. And I'm not sleeping very well at all. And all my sweaters are snagged. I mean, all of them.
Yeah, that sounds really hard.
It is. Thank you. Ow!
Oh, come on. If you would just...
So this is a meta-emotion mismatch, okay? So I gave them names, but this is Sally. She's trying to express her emotional pain, and Jim's like, we could just fix it right now if we took that nail out. And then she's like, no, you're invalidating me. I'm trying to tell you I'm in emotional pain. And then he's like, but this is so frustrating. If we just took the nail out, you wouldn't feel this way. And then in the end, this is a very disconnecting discussion where that's not what it was intended to be. It was intended to be very connecting. So this is the meta-emotion mismatch cycle. So what do you do if you're in that? We call this an emotional trap. So how do you get that shared coping style? How do you get your meta-emotions to match? The Gottman skill, this is the last skill I'll teach, is called a stress-reducing conversation. And this is when you have a stressor that is not about the relationship. So for example, in this video, her stressor was not about the relationship. She was just saying, I feel ache, I feel pain. Breast cancer is a stressor that, although it impacts the relationship, it is not about the relationship. Let's say you're feeling the stress, anxiety, depression, sadness around your cancer diagnosis or treatment. That's not about the relationship, that's about how you're feeling. So a stress-reducing conversation would be perfect for talking about breast cancer, your treatment. So it's a stressor not about the relationship. And essentially what you're doing is you're giving your partner space to just talk about what they're stressed about, how they're feeling, what's going on for them, what they're stressed about. And then you can ask, do you want me to just listen, or do you want any advice or problem solving? You can just straight up ask that, and more than likely they might say, I just want you to listen. I don't want to problem solve anything. So the speaker just shares their stress and you listen. And there are certain questions to ask. And so these questions are on the second side of your handout under the stress reducing conversation. As you're listening, you're not fixing the problem. You're not giving advice. You don't side with the enemy. So let's say your partner says like, oh, I just met with the oncologist and she was so dismissive. You don't say, well, I'm sure she's really busy. No. You just sided with the enemy. Instead, you say like, yeah, gosh, I'm so sorry that happened. And you listen with empathy. So as they're talking, you go like, yeah, I'd be frustrated too. So let's practice a stress-reducing conversation. You're gonna get into your pairs again. The speaker is going to speak about a stressor. The stressor cannot be about the relationship. The stressor has to be about something else. Work, cancer, something else. The listener is going to listen and is going to ask some very specific questions that are on the sheet, but I'll also put them on the projector. We're going to do this for about 5 minutes. Then you're going to switch roles, and the person who is listening is going to get a chance to speak for another 5 minutes. So here are the questions, and again, these are in your handout. The speaker is going to have a few minutes to just talk about what's stressing them out. Again, it can't be about the relationship. It's just whatever's stressing you out right now. The listener is going to ask the partner the following questions. And these questions sound similar. So you're going to ask question 2, and you're going to go, I think I just asked that. Doesn't matter. Still ask it, because you might get a different answer. So the listener is going to give their partner a couple minutes to talk about what's stressing them out, and then they're going to say, what is most upsetting to you about this? Partner speaks a little bit. What is it that you don't like about this situation? Partner speaks a little bit. And then the last thing you say is, what do you need? So you'll be asking these questions, and then you two will switch. Okay, so in your pairs, yes, question.
Question, I'm actually a problem solver, a woman who's a problem solver, and when I'm only offered feelings, I feel really like the person does not care about what I'm sharing, and that they only want to give me fluffy feelings back and not anything concrete. And I don't know what the question is in there per se, but I usually just respond with saying, hey, I'm a problem solver, I'd really like advice or solutions, and not just empathy right now.
Yeah, so you can, like at the beginning, let's say your partner's so you would be expressing something stressful, and then you're saying your partner would just give you fluffy feelings, and you're like, I don't want those fluffy feelings.
My partners are actually both problem solvers, but
if you were talking to someone who wasn't a problem solver.
Are not.
Yeah. Okay, so let's say
I'm a bad listener to them.
Let's say you're talking to a girlfriend who is not a problem solver and gives you a bunch of fluffy feelings.
Yeah.
Then you absolutely can say, actually, what I need right now is I just need help problem solving this. You can express what you need. And as long as you do that softly, instead of, you always give me fluffy feelings, right? There's the harsh startup. But just in the soft way, I'm a problem solver. I need problem solving help right now.
Cool. Can I ask one more question?
Of course.
Another cycle I find in that a lot is if they'll say, yes, I just want listening, or I want to do listening first, and then we'll talk solutions. And then when we get to solutions, like 98% of the time, there's like a reason for none of those. And so I'm always like, okay, I have no more solutions for you.
So you're saying if everyone hears each other and now it's problem solving time, and 99% of the solutions are just like unhelpful? Or
Well, it's just like, usually it's nothing to do with me. It'll be like, I think this thing about this problem, and I'd like to change how I feel about it. I'm like, okay, this, and they're like, oh, can't do that.
Oh, right. So someone's acting like they want your problem solving and advice.
Yeah.
You give them a bunch, and they shoot it all down.
Yeah.
I wonder if they really do want the problem solver advice, or if they just want the mushy feelings.
Well, I usually ask. And once it gets to that, I'm like, okay, I think maybe you didn't really want a solution.
Yeah. And maybe they don't even know, because they don't tap into their own feelings. They didn't even know that they wanted just the empathy or validation. Yeah, good questions. Okay, so let's jump into the pairs. One person gets to speak about a stressor. The other one listens and asks these 6 questions, and then we swap. There was one question in the back about, she was saying, like, I don't know how to respond to him. And what happened is that stress-reducing conversation ended up being about the relationship. And that makes it hard. If it's about the relationship and your partner's telling you, this is how you stress me out, then you're just sitting there and you're supposed to ask those 6 questions when you're probably getting more and more irritated or riled up. So that's why with a stress-reducing conversation, you really don't want it to be about the relationship. It's just about you and how you feel, what's going on for you. All right, I think this is my last slide. This is the take-home slide. So the Gottman skills that you learned today to tackle breast cancer as a team, turning towards each other to fill that emotional bank account. You want that 5-to-1 ratio. You learned the soften startup to express your needs in a soft way, not a harsh way. Then you learned how to respond with that Gottman-Rappaport exercise. It's a way to hear and be heard. And then you also learned the stress-reducing conversations to reduce stress about a stressor that is not about the relationship. You can download the Turning Towards exercise at this link, and then you all have the handouts, but if you want them digitally, you can download them from this link as well. And thank you, everybody. And I'll still be here if there are questions.